This is Dr. Tracy Zhang with Oral Pathology for Dental Hygienists. Today, we're going to talk about an introduction to preliminary diagnosis of oral lesions. The first objective is to list and define the 8 diagnostic categories that contribute to the diagnostic process. I would also like for you to be able to identify the conditions in the photographs in this presentation, and also your variant of normal presentation. To begin our preliminary exploration of oral diagnosis, we're going to examine the 8 categories of oral diagnosis, as listed in your textbook, Oral Pathology for the Dental Hygienist, by Olga Ibsen and Joan Anderson Phelan. The 8 categories include the following: clinical, historical, radiographic, laboratory, microscopic, surgical, and therapeutic. Differential diagnosis is the last category, and that involves a short list of the most likely possibilities that a condition or lesion could be. The first category we're going to explore is clinical diagnosis. Clinical diagnosis suggests that the strength of the diagnosis comes from the clinical appearance of the lesion, as noted in your textbook. There are many lesions that can be diagnosed clinically. As you can see on the screen, mandibular tori is definitely something that you're able to diagnose clinically, and you've probably seen several of these already. Other examples of lesions that can be diagnosed clinically include Fordyce granules, melanin pigmentation, retrocuspid papillae, lingual varicosities, just to name a few. Some conditions, such as geographic tongue, can also be diagnosed clinically. This can also have a historical component, which is our next category. Because when you see a lesion such as this on your patient's tongue, one of the first questions you need to ask your patient is, have you noticed that this is there, and how long has it been there? Patients who have a geographic tongue have had it most of their lives and will be able to tell you a great deal about the lesion. They'll tell you that it comes and goes, and frequently that when it comes back it's in a different place. And that's a good introduction to historical diagnosis. Historical diagnosis is a diagnostic category in which the strength of the diagnosis comes from the patient history of the lesion or their condition that they give you. Some examples of historical diagnosis include AMELOGENESIS imperfecta, for example, or DENTINOGENESIS imperfecta. Both of these are genetic conditions that affect all of the teeth that the patient has, both primary and permanent. Historical diagnosis relies significantly on the patient health history as well as the history of the lesion or condition, as I've mentioned. There are a number of other disorders that can be included in historical diagnosis, such as drug history. Radiographic diagnosis is our next category. Radiographic diagnosis is a diagnostic category in which the strength of the diagnosis relies, for the most part, on the radiographic image that you have taken or that you have received as a referral. Note that in this particular film, this is an occlusal film, this is a patient who has primary teeth and permanent teeth. And notice also that there's an extra tooth that we call a supernumerary tooth in the picture. A supernumerary tooth that is between number 8 and 9 is called a mesiodens. So if you see this picture on an exam and I ask you the name of this condition, instead of supernumerary tooth, which is correct but more general, I prefer that you respond with mesiodens, because that tells me it's both a supernumerary tooth and also the location, which is typically between 8 and 9. There are a number of other supernumerary tooth locations that we often see, such as 4th and 5th molars. Some patients have extra teeth elsewhere, but not necessarily in the middle between 8 and 9, right in the median plane. So remember that this particular tooth, supernumerary tooth, that's between 8 and 9, is a mesiodens. There are many conditions that we diagnose using radiographs. We diagnose caries, impacted teeth, periodontal bone loss, although the strength of periodontal diagnosis generally relies on your periodontal assessments. However, frequently you can see periodontal bone loss on an X-ray such as this. It's obvious with this X-ray that your probe is going to bury itself in the gingiva for this patient. This radiograph depicts a periodontal periapical cyst that was probably a result of caries or periodontal situations, or both, as you can see here. Many other conditions can be diagnosed using radiograph. For example, this particular X-ray shown here from a video made by dental students Matthew Freyer and Logan Veith that was posted on YouTube show internal resorption. Note this radiolucent dark area in the center of this tooth. Sometimes the odontoclasts become activated and begin to take away tooth structure, and that can cause internal resorption. Sometimes we'll see external resorption as well, and that's a condition where the tip of the root typically, or another part of the root of the tooth, appears to having been eaten away on the X-ray. So we've seen clinical diagnosis, historical diagnosis, and radiographic diagnosis. This picture shows you two different conditions. One is a clinical diagnosis, which shows you a leukoplakia, which simply means white lesion, but it's a very white lesion in the anterior vestibule that's corrugated. It's a smoker's keratosis. Contrast that with microscopic diagnosis. Microscopic diagnosis is a sample, such as a biopsy, that's taken from a lesion that the patient has and then placed under a microscope to show an image such as this. This is an image of lichen simplex that the patient had. Surgical diagnosis is another diagnostic category. There are several lesions that are diagnosed during the surgical procedure. For example, in this particular X-ray, we see a radiolucent area that's not a normal presentation close to the angle of the mandible on this patient. When the surgeon went in, it became obvious that this was what's called a STAFNE bone cyst, which is not a true cyst. This is a pseudocyst or fake cyst. It looks like a cyst on the radiograph, but when the surgeon went in, they found that it was a bony defect. More commonly, you'll see a cyst such as traumatic bone cysts diagnosed with surgical diagnosis. A traumatic bone cyst often presents as you see in this film here from Dr. Shawneen M. Gonzalez. Notice how the radiolucent area scallops around the roots of the teeth. There is no typical bone trabeculation pattern here as you see further up. So this is a very typical traumatic bone cyst. Therapeutic diagnosis involves using a therapeutic agent such as nystatin fungal cream or an antibiotic or a rinse or peroxide to treat a patient's condition. This particular film shows necrotizing ulcerative gingivitis, as you can see from the necrotic tissue in the interdental papillae. A typical treatment for NUG, necrotic ulcerative gingivitis, is to have the patient rinse with hydrogen peroxide because the oxygenated environment is incompatible with the bacteria that causes NUG. Generally, for a patient with NUG, we'll have them come in for a scaling and root planing, clean the area thoroughly, and then treat them with a rinse such as hydrogen peroxide and sometimes Peridex. And we'll also discuss other factors with them from their health history, because frequently patients who come down with NUG are immune suppressed in some way. When I was in dental hygiene school, we often saw NUG on students during finals week or midterms, because that's a very stressful time for students. Another typical therapeutic diagnosis that you may often see is Candida. This picture shows angular cheilitis, which is associated with Candida. Here's another picture of a more typical oral candidiasis. We would treat this with a prescription for nystatin, which is an antifungal cream, if you remember from pharmacology, and then we would have the patient return in 2 weeks for an evaluation and see if the treatment therapeutic agent, in this case nystatin, did the job and took care of the condition. And that would provide the strength of the diagnosis as a therapeutic diagnosis. So to review, we've gone over the 8 diagnostic categories for the most part. We've gone through clinical, radiographic, historical, laboratory, microscopic, surgical, and therapeutic diagnosis. The last category is differential diagnosis. Differential diagnosis is a list of the top 3 most likely conditions that a lesion or condition could be, based on all of the previous diagnostic categories and any other assessments that you have performed. For example, you may have ordered laboratory diagnosis type studies. You may have ordered a blood test for a patient that you may suspect of having Paget's disease. A typical blood test that we might order for that type of patient would be serum alkaline phosphatase. So blood tests will play a role in your differential diagnosis, just like the rest of the categories. During this class, I will frequently ask you, what's your diff? And that means, what is your differential diagnosis for the condition that we're studying, or the case that we're looking at? And it's an important skill to develop in oral pathology. Notice also on this presentation, which will be posted in Sakai in our learning management system, that I've listed several useful oral pathology sites as well. I strongly encourage you to follow any links that I place on the presentations to maximize your learning in this course. There's a lot of great information there, and also on links scattered throughout the presentations for you. Our references today were from Phelan and Ibsen, your textbook, Oral Pathology for the Dental Hygienist for the most part, with some information from Newland and Cosson. So that's our first edition from Oral Pathology for the Dental Hygienist.